Hi students, I welcome you all to this very important session, and that is a session on instruments in OBS and gynae. Now this session is important for all the students who are going to appear for their PG entrance exam, now be it AIMS, be it PGI, JIPMER, and also for students who are going to give their FMG exam. Not only that, students who are in their final year, in their Viva, you will be shown an instrument and you will be asked about that instrument. So a very important session for all of you. Hi, I'm Dr. Sakshi Arora Hans, a faculty in OBS and gynae, and this is what I'm going to tell you, the instruments in OBS and gynae. Now, as far as questions on instruments are concerned, if we see the PG entrance students, what are you supposed to know? See, you have to identify the instrument, number one. Number two, not only that, because in your image-based question, you can be given an instrument. Not only that, they may show you an image of an instrument and they may ask you, what is it used for, right? Now, what about the final year students? See, final year students, you will be given an instrument in your hand and your Viva to recognize it. So you should know how to recognize the instrument. Number two, again, you should be knowing at least two uses of each of the instruments. And you should also be having a knowledge about the related topics, right? Because your Viva can go to related topics. So in this session today, I am not only going to tell you how to recognize an instrument and what are the uses, I am also going to tell the final year students what are the related topics on which Viva can go when they have the instrument in their hand, right? So the first, I'm going to start with all the instruments which are used to examine the vagina per vaginally, right? Before I start telling you what are the instruments which are used for examining the vagina, cervix, etc., I want to talk to you a little bit about the anatomy of vagina and the anatomy of the cervix. So I have tried to recreate a model of cervix and vagina here. See, in cervix, we have two parts of the cervix. A part of the cervix, which is I'm saying is this part, this is what I have made is endocervix, right? So you all know that endocervix is the part of the cervix which is closer to the uterus. So over here, there will be a uterus, which I haven't made. So this part of the cervix, which lies closer to the uterus, is the endocervix, and it is, all of you know that it is lined by the columnar epithelium. And because this part of the cervix is above the vagina, so this blue colored part which I have made is the vagina. So it is also called as the supravaginal part of the cervix, right? Now, the part of the cervix which is inside the vagina, which I have made with pink color, right? That is the exocervix. And that is also called as the portio vaginalis, and it is lined by the stratified squamous epithelium, right? Now, this opening over here, this is the opening of the external os, right? Now, when you do a per speculum examination, which I'm going to tell you how you are going to do a per speculum examination and what are the instruments which you are going to use to examine the cervix. So when you do a per speculum examination, the pink colored part which you see, that is always the exocervix, right? And a red colored part, whatever little bit red colored part which you will see will be the endocervix, which is visible from the external os. Now, since endocervix is lined by columnar epithelium and exocervix is lined by the stratified squamous epithelium, the place at which the epithelium changes, that is the columnar epithelium of endocervix, it changes into the squamous epithelium of exocervix. That is called as the transformation zone. Now, the position of the transformation zone, it keeps on varying with the hormonal status of the female, but mostly it is near the external os. And when you will do a per speculum examination, it will appear white in color, right? So faded appearance it is going to give. So the pink colored part is the exocervix. This white colored part, whatever you are seeing over here, is the transformation zone. The pale part, actually it's not the white part I should say it's the pale part which you are seeing. And whatever red colored part, what you see is the endocervix, right? Now, what is internal os? Internal os is the place where the endocervix is going to open into the uterus, right? So we have an external os and the internal os. Clear? Now look over here. So in this image over here, the pink colored part will be the exocervix. Whatever red colored part you are seeing will be the endocervix, and in between them, whatever pale area you will get will be the transformation zone, right? Now, suppose if a lot of red area starts appearing on the pink area, that means endocervix has moved out, and that is what is called as the ectropion. Ectropion. So, in image B, you can see a lot of red colored area. That means endocervix has moved out, right? Okay. Now, if I want to do a per speculum examination, I want to look at the cervix. First thing what I will have to do is, I will have to retract the posterior wall of vagina, right? So this blue color is the vagina which I have drawn. So in order to retract the posterior wall of vagina, the instrument which I am going to use is double-bladed, non-self-retaining Sims speculum. Why I am saying the full name is because for the final year students, when you are going to give your Viva, you have to say the complete name. So this is Sims double-bladed, non-self-retaining vaginal speculum. The other name for this speculum is the duckbill speculum. As you can see, in this speculum, there are two blades, right? One blade, the size of both the blades will be different. One blade will be a little narrow and the other blade will be a little broader, right? Then there will be a handle which will be connecting both the blades, and there will be a groove in the blade. Now, this groove in the blade is for the drainage of any discharge, right? Now, this is a posterior vaginal wall retractor, so I am going to retract the posterior vaginal wall with it, like this. Since it is non-self-retaining, I will have to have an assistant to hold it, right? So this Sims speculum, where is it used? It is used for in all the, whenever you have to examine the cervix. For any reason, if you have to examine the cervix, so you will have to retract the posterior vaginal wall and you are going to use this Sims speculum there. Number two, if you are doing some minor procedures, like if you want to insert an IUCD, or if you want to remove an IUCD for that matter, or if you want to collect a pap smear, or if you have to do endometrial biopsy, in all these cases, you will need a Sims speculum. For minor gynae surgeries, vaginal surgeries, and for major gynae vaginal surgeries, again, you will need a Sims speculum. Also, a Sims speculum can be used for the rupture of membranes in order to identify the rupture of membranes, right? So, in rupture of membranes, you can put the Sims speculum, and you can also ask, if you're not sure whether the membranes have ruptured or not, because it is not a complete rupture. It is just, some fluid is coming out. It's not that a gush of water has come out. In that case, you can put the Sims speculum and you can ask the female to cough. And if anterior amniotic fluid can be seen coming out, that means yes, the membranes have ruptured. So in case of rupture of membranes, whether it is premature rupture of membranes or the rupture of membranes, you can go for a sterile per speculum examination. In rupture of membranes, per vaginal examination is contraindicated, but a sterile per speculum examination can be done, right? So this is a Sims speculum. A Sims speculum should be used in conjunction with a Sims anterior vaginal wall retractor. So if I have retracted the posterior wall, now I need to retract the anterior wall. right? The anterior wall is retracted with this instrument. This instrument is the anterior vaginal wall retractor. As you can see, this is a tubular instrument which has got two loop-like ends, two ring-like ends, right? Now, in the ring-like ends, you have to note that there are serrations which are present, right? So, let me open an image also. So, there are serrations or fenestrations which are present in the loop-like end. Why are these fenestrations present? So that they can fit into the rugosities of the vagina. Now, if you see over here, the loop-like ends, they are making an angle with the handle, right? So they are making an angle. This is a 15-degree angle which they make with the handle, and both the loops are pointing in opposite direction. One of the loop will be pointing anteriorly, the other loop would be pointing posteriorly. When you are inserting the anterior vaginal wall retractor, the loop should be facing above, right? Anteriorly, like this. So you are going to introduce it in such a manner that the loop faces up anteriorly, right? So this is how you are going to use the Sims anterior vaginal wall retractor, which has to be used in conjunction with the Sims speculum. Sims speculum is going to retract the posterior vaginal wall, and the Sims anterior vaginal wall retractor or the AV retractor will retract the anterior wall of vagina, right? Now, apart from being used as the anterior vaginal wall retractor, rarely you can also use it as a blunt curate in OBS, but that's only if final year students, if the examiner is bent upon asking you what is the other use, right? One thing which you have to remember is normally a Sims speculum is used in conjunction with the anterior vaginal wall retractor, but if you are using Sims speculum in Sims position, and I'll tell you what Sims position is just now. In that case, you don't need an AV retractor. Why? Because in that case, air will come in and it will open the walls of the vagina, right? So, Viva question. All these instruments which have the name Sims, on whom are these names Sims based on? So, this name Sims is based on a surgeon who was from US, and his name was James Marion Sims. James Marion Sims is also the father of gynecology surgery. Now, there are various things by the names of Sims, and in Viva you can be asked that. So, number one, you have a Sims speculum. Number two, you have Sims position. Now, what is Sims position? In Sims position, you ask your patient to lie in prone position facing towards the left side, right? So, the patient has to be facing towards the left side. The right arm and right leg are extended. They have to be in extended position, whereas left arm and left leg will be flexed. Right? This position is called as the Sims position. Sims position is very important because if you want to look at, if you want to examine the vagina, you can examine vagina in this position. For rectal examination, you can use this position, and you use this position to give the enema, right? So this is what is Sims position, in which the patient is going to lie prone facing towards the left hand side. Right hand side leg and right hand side arms will be fully extended. Left hand side arm and left hand side legs will be flexed, right? So number one, I told you based on the name Sims was Sims speculum. Number two, there can be Sims position. Number three, there is a Sims method for VVF repair. Together, these three, 1, 2 and 3 are called as Sims triad. A very important Viva question, that what is Sims triad, right? Apart from this, yes, we have the Sims anterior vaginal wall retractor, and yeah, that's it. So these are the things which we have based on the name Sims, right? Now, the biggest disadvantage of a Sims speculum is that it is non-self-retaining. So, if I am using a Sims speculum and I am using the anterior vaginal wall retractor, I will need assistance, right? This disadvantage, it can be overcome if I am using this speculum. This is a Coscos bi-blade speculum or a double-bladed self-retaining speculum, right? So over here I have Coscos bi-valved self-retaining vaginal speculum, right? Complete name is important for the final year students. Rest of all who are going to give their PG entrance or FMGE, this is a Coscos speculum, right? Now in Coscos speculum, it has double blades. So my Coscos is a little old now, right? Now I am going to insert the Coscos speculum and then I am going to tighten the screw over here, right? When I will tighten the screw over here, the Coscos is going to tighten and it is a self-retaining speculum. So my hands are now free for whatever procedure I need to do, right? The advantage of Coscos speculum is that it is self-retaining. So it can be used for examining the cervix in OPDs, and it can also be used for minor OPD procedures like if you want to insert an IUCD, remove an IUCD, if you want to do an endometrial biopsy or for pap smear. But there are two problems with Coscos also. One problem with Cosco is that the anterior wall of vagina and the posterior wall of vagina cannot be seen. So if I am suspecting any problem in the anterior and the posterior wall of vagina, they cannot be seen with a Coscos speculum. Whereas with a Sims speculum, if I am putting the Sims speculum, normally we put it in the posterior wall. So yes, the posterior wall cannot be seen, but anterior can be seen. But just in case I want to examine the posterior wall, then always I can shift it to the anterior wall like this and I can examine, right? This cannot be done with Coscos. So that was one problem with Coscos. The second problem with Coscos is that here you are getting very less space. So this Coscos speculum, it cannot be used if you are doing minor or major gynae surgeries. That is the biggest problem with Coscos, right? So this was Coscos speculum. So, and the earlier which we did was a Sims speculum. This is self-retaining, that was non-self-retaining speculum, right? Now, sometimes you can get an image like this, where in Coscos you can see a smoke retractor. This is a Coscos which has a Teflon coating and it has a smoke retractor. This smoke retractor, a Coscos speculum with smoke retractor, it is used when you are cauterizing the cervix, right? So for cauterization of cervix, you use a Coscos speculum with a smoke retractor, right? Now, I want all of you to look at this image over here and try to identify the instrument which is shown here. This instrument is definitely broader than a Sims speculum. This instrument is Orward's weighted self-retaining posterior vaginal wall speculum. So it's Orward weighted self-retaining posterior vaginal wall retractor. I don't have this instrument here. We will see this instrument on the image. Now, if you see this speculum over here, very easy to identify because this is the only speculum which will have a very heavy weight attached to it. So no difficulty in identifying this instrument, and again it has a groove and that groove is for drainage of blood, right? Now how is it self-retaining? Coscos was self-retaining because it had a screw, but this doesn't have a screw. How is it that it is self-retaining? Number one, because the blade and the handle, the angle which they make is less than 90 degrees and it has weight attached to it. Both these features, they make Orward's speculum a self-retaining speculum. Now, overt speculum should not be used in OPD procedures. You know, if you want to examine the cervix, you shouldn't use overt speculum. Why? Because this speculum is used only in lithotomy position, number one. Number two, it is used only under anesthesia. It has weight attached to it. It has to be used only under anesthesia, and when you remove it, so many times patient is going to complain of post-operative pain due to stretching. And it cannot be used in OPD, so it cannot be used for per speculum examination, right? Where are you going to use overt speculum? You are going to use overt speculum when you are doing vaginal surgeries, right? In vaginal surgery, I cannot use a self-retaining Coscos speculum. And for vaginal surgeries, I cannot throughout the surgery ask an assistant to hold the Sims speculum. I need a speculum which gives me good area to operate and is self-retaining. And overt serves both these purposes, right? It will give you a proper area to operate and it is self-retaining. So when you are doing vaginal hysterectomy or you are doing TVTs, that is the tension-free transvaginal obturator tape, tension-free transvaginal tapes, or you are doing anterior colporrhaphy, in all these things, in all these surgeries, you are going to use overt self-retaining speculum, right? Now, once I have retracted the posterior wall of vagina and I have retracted the anterior wall of vagina, if I want to enter into the cervix, I will need to hold the anterior lip of the cervix. Now, in order to hold the anterior lip of the cervix, the instrument which I am going to use is the Cellum, right? I am going to use the Cellum to hold the lip of the cervix. Now, I want all of you to have a very look good at this instrument. At the distal end, it has a ratchet lock, right? In the proximal end, you can see that it is curved and it has a concavity, right? Between the blades, what I want you to notice is the gap between the blades, right? So notice the concavity which is there. Notice the gap which is present between the blades. Now, look at the tip of this instrument. The tip of this instrument has got multiple small teeth which are called as rat teeth. 4 to 5 rat teeth. So, this is a Cellum. Again, you have a ratchet lock. So, here you have a ratchet lock. Then, at the anterior end, look at the blades. They are curved. That's a concavity which is present there. This concavity, I'm just now going to apply it and show to you that when you are going to apply Cellum, the concavity should face upwards, right? So this concavity should face upwards. Then on opening at the tip, you see 4 to 5 rat teeth. Clear? Now, with this instrument, with the concavity upwards, I'm going to hold the anterior lip of the cervix. The anterior lip of the cervix will be held like this. Usually, we hold the anterior lip of the cervix, right? But a Viva question could be that what are the conditions in which you have to hold the posterior lip of the cervix? So imagine, if I have to hold the posterior lip of the cervix, what am I targeting? I am targeting to look at the posterior fornix. This is the anterior part, this is the posterior part. So if I am holding the posterior lip, my aim is to visualize the posterior fornix and to do procedures through the posterior fornix. So what are the procedures which you do via the posterior fornix? Number one, culdocentesis. Culdocentesis is one procedure which would go via the posterior fornix into the Caldi sac. Colpopuncture. Again, number two, if you want to drain a pelvic abscess, that is posterior colpotomy, in that case, you will have to hold the posterior lip of the cervix. Number three, suppose if you have to take any biopsy from the anterior lip of the cervix. So in that case, you are going to hold the posterior lip, right? So if you have to take any biopsy from the anterior lip. So these are the places where you have to hold the posterior lip of the cervix. So as I told you, one use of Cellum is to hold the lips of the cervix, and that's the main use. Apart from that, Cellum can be used to hold the fundus of the uterus and to manipulate the fundus of the uterus while you are doing abdominal hysterectomy, and it can be used to grasp the fibroids while you are doing myomectomy, right? So they are the other uses of the Cellum, right? Now, if you see over here, Cellum has teeth, so it is going to grasp the cervix, right? The lip of the cervix very tightly. And all of you know that in pregnancy, the cervix is very soft. So if you grasp the cervix with a Cellum, that is going to lead to a lot of bleeding. So in pregnant females, if you have to hold the lip of the cervix, what instrument do you use? In pregnant females, you do not use a Cellum, you use a sponge holding forceps. Clear? Non-pregnant females, Cellum. Pregnant females, a sponge holding forceps. Now, if you've understood this much, understand one more concept. If the female, the non-pregnant female whom you are examining is a nulliparous female, then her external os will be pinpoint. In that case, I am going to hold the lip of the cervix by using an instrument which will have a single tooth. And this instrument is called as either a single-toothed Cellum or you call it as a Tenaculum. So this over here, I don't have a Tenaculum to show you. So this instrument over here, if you see, it is holding the lips of the cervix, but it has a single tooth. Over here, the single tooth. A single-toothed Cellum has a special name, Tenaculum. So now I have told you three conditions. Three instruments, right? Number one, if you have to hold a non-pregnant multiparous female's cervix, you are going to use a Cellum. If you have to hold a non-pregnant nulliparous female's cervix, you are going to use a Tenaculum. And if you have to hold a pregnant female's cervix, and when do you hold a pregnant female's cervix? When you are doing a cervical cerclage. Or suppose immediately after delivery, still the cervix is going to be very soft. So immediately after delivery, if there is a cervical tear, in that case, you have to hold the soft cervix again. You are going to use a sponge holding forceps. Clear? I hope this instrument is very clear to you. Again, look at it, the gap between the blades, the concavity and the rat teeth, right? Now, so in this slide, I have told you about Tenaculum, how to identify it. Tenaculum is single-toothed, rest everything is like your Cellum. Now, in this slide, I told you for holding the cervix, the lips of the cervix in a pregnant female, you use a sponge holding forceps. So let's have a look at how a sponge holding forceps looks like. This over here is a sponge holding forceps. Now remember, most of the forceps which we are going to study, they will have a ratchet lock. I am going to tell you only two forceps in which this lock is not there. But I'll come to that later. But first of all, most of the forceps will have a lock. Now, if you see its distal end over here, the distal end is ring shaped, right? And when you open the rings, you see serrations present on the rings, right? So it is ring shaped, it has a hole in the center, and when you open it, you see serrations. What do you use a sponge holding forceps for? You use a sponge holding forceps to paint, you pick up the swabs, cotton swab, and you paint the part before doing any surgery. Now, whether it is abdominal surgery or whether it is vaginal surgery, before doing any surgery, painting of the part is done with the help of a swab which you are going to pick up with a sponge holding forceps, right? Again, the second use of sponge holding forceps will be that it is used for holding the lips of the pregnant female, right? And lips of the pregnant female are held for cervical cerclage. Then third use is if you want to identify any cervical tears. Now, when you have to identify a cervical tear, you need at least 2 sponge holding forceps. What you do is, one sponge holding forceps, you put it at 12 o'clock position, and the other you put it at, suppose this is a sponge holding forceps. This is not a sponge holding forceps, but I'm just saying imagine. Right? So one sponge holding forceps at 12 o'clock position, other at 3 o'clock position. This much part of the cervix, so I'll just show you here. One sponge holding forceps at 12 o'clock position. I don't have another sponge holding forceps. Another sponge holding forceps at 3 o'clock position. So you will examine the cervix like this. Now, the one which is at 12 o'clock, you are going to remove that from there and you're going to put it at the 6 o'clock position. The 3 o'clock position sponge holding forceps will remain like that, right? So you are going to now examine the cervix between 3 o'clock and 6 o'clock. Now you will remove the one which was placed at 3 o'clock and put it at 9 o'clock. So you're going to examine the cervix between 6 o'clock and 9 o'clock. Now the one which was at 6 o'clock, you're going to take it to 12 o'clock and you are going to examine the cervix between 9 and 12 o'clock. So this is how you identify cervical tears, right? Then, suppose you are doing any pelvic surgery and you want to apply pressure on any bleeder at that part. So, in that case also, I can pick up a swab with this sponge holding forceps. I can go deep into the pelvis and I can apply pressure, right? And now, the last use of sponge holding forceps could be during LSCS. When you have given a uterine incision and once the baby is delivered, now you want to stitch the uterine incision. So you can hold the edges of the incision with sponge holding forceps. See, this is not the ideal forceps for that use. Ideal forceps to hold the edges of the uterus is either a green armitage forceps or an Alice forceps. But yes, if you have neither of them, which is highly unlikely, then you can use a sponge holding forceps also, right? So these were the uses of the sponge holding forceps. Now, in order to hold sponges, in order to paint or to hold a swab, you were using a sponge holding forceps. What about transferring the instrument from the boiler? If you have to transfer a sterile instrument from the boiler, then the forceps which you use is a chittels forceps. I don't have a chittel forceps, so look in the image which I'm showing you. A chittel forceps has a curved tip. It's very easy to recognize. It will have a curved tip, and when you will open the tip, there will be multiple serrations which are present. Very typical tip, right? And there is no lock. As I told you, I'm going to tell you 2 forceps which don't have a lock. One of them is a chittel forceps, so no lock. One is chittel forceps and the other is ovum forceps. Right? Only 2 forceps which you use in OBS which don't have a lock are these, and it's very easy to differentiate chittels forceps from a spoon-shaped ovum forceps, right? What is chittels forceps used for? It is used to remove sterilized instruments from the boilers and formalin cabinets. They are used to ensure that as each item is removed, others are not infected. Now, this chittels forceps, it should be contained in a container of methylated spirit when it is not in use, right? Now, once you have held the anterior lip of the cervix with the valcellum, now suppose you have to do a dilatation and a curettage, or you have to do MTP by suction evacuation. In either cases, whenever you have to insert any instrument inside the uterus, there are 2 things for which you should be sure of. Number 1, you should be sure of the position of the uterus, whether the uterus is anteverted or whether the uterus is retroverted. Number 2, you should be sure of the length of the uterus, the uterocervical length, so that you know how much the instrument should go inside. And for that purpose, we use a uterine sound. So this over here is a uterine sound. Now, if you look at a uterine sound, you will see that it is a metal tube which is angulated. The angle is pronounced, but it is very smooth, right? So it's angulated. It has a tip which is round and it has a special name. This tip has a special name that is called as olive tip. The purpose of this olive tip is it prevents perforation. And the next thing which you should note over here is that it is calibrated. So starting from 4 centimeters, it is going up till 30 centimeters, right? Because it is used to measure the uterocervical length. So again, I'm telling you, it is a metal tube. It has a prominent angle, but the angle is smooth, right? A prominent smooth angle, olive tip, and it is calibrated, right? Now, there are 2 purposes which this uterine sound is going to fulfill. Number 1, it is going to tell you the uterocervical length. Number 2, it is going to tell you the direction of the uterus. And when you are putting the sound inside to know either of these, this is called as sounding, right? Now, apart from this, a uterine sound can help you to locate a misplaced IUCD. So, if an IUCD is misplaced and you want to see whether the misplaced IUCD is inside the uterus or it is outside the uterus, you put a uterine sound and then you get an X-ray done. If the IUCD is close to the uterine sound, you come to know that yes, it is within the uterus. If it is far, then you come to know that it is outside the uterus. Apart from that, a uterine sound can help you to detect uterine anomalies like a septa inside the uterus, right? So these were the uses of a uterine sound. Now let's talk about the Viva questions which can be asked on uterine sound. Number 1, when you are holding, final year students, when you are holding the uterine sound, first thing which the examiner can ask you is that what is the normal uterocervical length? So remember, the normal uterocervical length is 2.5 inches. In other words, if they ask you in centimeters, it is between 6 to 8 centimeters. Second thing which they can ask you is what is the corpus to cervix ratio in adults? So corpus, that is the uterine body, is called as the corpus. So corpus to cervix ratio in adults is 2:1, or it can be 3:1 also. But remember, in childhood, this ratio is reversed. In children, it is the cervix which is longer than the uterus. So this ratio in children is 1:2. The corpus to cervix ratio is 1:2. Then when you are holding this uterine sound, the examiner might ask you that why is it olive tipped? So as I told you just now, it is olive tipped to prevent perforation. But just in case perforation happens, what are you going to do next? So your question can come as a PG entrance student also. They can show you this instrument and they can ask you, if perforation happens with this instrument, what is the next step? So option A, immediate laparoscopy. Option B, immediate laparotomy. Option C, stop the procedure immediately and wait and watch. Option D, continue the procedure. So it is not A, B, it's C and D, right? So if perforation is happening with an instrument which is as narrow as a uterine sound, you don't need to do a laparotomy, no laparoscopy, just wait and watch. Just stop the procedure and wait and watch. You have to look at the vitals of the patient, right? This is why before putting any other instrument, we are putting a uterine sound, because it is very narrow, so it can also act as the first dilator, right? So it acts as a first dilator also, this uterine sound. And if perforation happens with this, nothing to worry, just wait and watch the vitals of the patient, right? Now, next question which the examiner might ask you is, what are the conditions in which the uterocervical length is increased? So suppose if perforation has happened, so suppose I am inserting this sound and this sound perforates the uterus. Now, in that case, I'm going to get the length of the uterus very big. I'm going to measure the length. I'm going to say, oh, this is so big length. So that means uterocervical length can be increased if there is perforation of the uterus. Or suppose if there is supravaginal elongation of the cervix. So if supravaginal part of the cervix has elongated, then in that case also the uterocervical length will increase. Or if there is congenital elongation of the cervix, there are few females in whom the cervix is congenitally elongated. Now the moment you are going to say this, the next question which examiner is going to definitely ask you and will be very impressed if you give the correct answer is, how do you differentiate supravaginal elongation of the cervix from congenital elongation of the cervix? So remember, supravaginal elongation of the cervix is seen when the uterus prolapses. And in that case, the fornixes, these fornices over here, they will become more deep. So if you are getting very deep fornices, that means there is supravaginal elongation of the cervix. But if the fornix are normal, then that means it's a congenital elongation of the cervix. And in pregnancy, see, in pregnancy, normally the length of the cervix is 2.5 centimeters, 1.25 being the endocervix and 1.25 being the exocervix. In pregnancy, the length of the cervix becomes 4 to 5 centimeters. So definitely there will be increased uterocervical length. Not only the cervix length size is increasing in pregnancy, the size of the uterus is also increasing in pregnancy, right? So this is another very important cause for increased uterocervical length. Now, let's talk about those conditions where the uterocervical length is decreased. The uterocervical length will decrease in menopause. Why? Because in menopause, both the uterus and cervix are going to undergo atrophy. Suppose if there is a chronic inversion of the uterus has inverted, the fundus of the uterus has dipped down. Now, if the fundus of the uterus has dipped down, obviously the uterocervical length is going to decrease. Or suppose if you have done amputation of the cervix like you do in Fothergill's repair. In Fothergill's repair or Manchester surgery, you do amputation of the cervix. So definitely the uterocervical length will decrease. And in congenital hypoplastic uterus, the uterocervical length will decrease. Right? So these are all the possible questions which can be asked when you hold a uterine sound. But the most important question which the examiner is going to ask you the moment they give you a uterine sound is, they will say, have you seen a bladder sound? How do you differentiate a bladder sound from a uterine sound? So I don't have a bladder sound. I want you to look at the image here. In the image, what I want you to see is that in the bladder, this curve over here is very gentle. In uterine sound, this was a very pronounced curve. As I told you, it's angulated, it's smooth, but it's very prominent, right? But here, it's a very gentle curve. And the second and the most important difference is that in a bladder sound, you won't get any markings here. Whereas in uterine sound, you will get markings here, right? So, I have introduced the sound and I have come to know that what is the length of the uterocervical canal, right? Now, suppose I have to do a suction evacuation, or if I have to go for dilatation and evacuation, what I will have to do is I will have to dilate the internal os. Now, in order to dilate the internal os, I can use a set of dilators. This is a set of dilators, double-bladed dilators, which is called as Hagars dilators, right? So, these are the Hagars dilators. Hagars dilators, they have double end. One end is a little narrower than the other end. They have numbers written over here which tell you what number dilator it is, right? Now, this image over here is an Hawken-Amber dilator. A Hawken-Amber dilator is always single-ended. Hagar's dilator usually is double-ended, but it may be single-ended. A Hawken-Amber dilator, it will have a blunt tip. See over here, it's round, but it's pointed little. There they will have a blunt tip and they will have a thumb rest. Right? So you will have a thumb rest which you won't have in case of Hagars dilator. Purpose of these dilators is to dilate the cervix before performing procedures like dilatation and evacuation, or before performing suction and evacuation, or before you insert any other instrument. You are going to insert instrument during HSG, you have to put an HSG cannula. So before you put an HSG cannula, you will have to dilate the cervix, or before you do hysteroscopy, right? So before you put a hysteroscope, again, you will have to dilate the cervix. Then you will also have to do a dilatation before certain surgeries like polypectomy. So if you have to do a polypectomy, you will have to dilate the internal os first. Or suppose when you are doing Fothergill's repair. Now, when you are doing Fothergill's repair, one of the part of Fothergill's repair is amputation of the cervix. When you amputate the cervix, after amputation, there is a lot of additions there, a lot of fibrosis there, and that leads to stenosis of the cervix. So in order to prevent stenosis of the cervix after surgery, before performing amputation of the cervix, we dilate the cervix, right? So that is prophylactic dilatation which we do before performing amputation of the cervix in Fothergill's repair. And also you will have to dilate the internal os when you have to drain pus from the uterus, like in case of pyometra, right? So these were the uses of Hagars dilators. Now, Viva questions which can be asked on Hagars dilators are: what is the maximum dilatation which can be done in a non-pregnant female? In a non-pregnant female, usually we dilate up till 10 number, but maximum you can take it up till 12. Then in a primigravida female, you can go up till 12 to 14 number, and in a multigravida female, you can go up till 16 number dilatation. Before you dilate, do you have to give any anesthesia? See, dilatation can be painful. So in order to prevent pain, you can give a paracervical block. Now, when you say paracervical block, the examiner is going to ask you at what sites do you give a paracervical block. So a paracervical block is given either at 2 o'clock and 10 o'clock position, or at 4 o'clock and 8 o'clock position, right? So either you are going to give a paracervical block at 2 o'clock and 10 o'clock position, or you are going to give a paracervical block at 4 o'clock and 8 o'clock position. You never give paracervical block at 3 o'clock and 9 o'clock position. Why? Why? Because descending cervical arteries, they are present at 3 o'clock and 9 o'clock position. So never am I going to give a paracervical block at 3 o'clock or 9 o'clock position, right? Now, when you are dilating, what are the complications which can happen? Number one, due to pain, they can be vasovagal shock. Number two, it can lead to perforation of the uterus. Again, if perforation happens with Hagars dilators, you have to wait and watch. You have to watch the vitals of the patient. Remember, when you are dilating, you have to start dilating from the thinnest one, the one which has the smallest diameter, and then you gradually increase and go up till the one which has a maximum diameter. Hagars dilator, they are 12 in number, starting from number 3 and going up till 26. So each end will have a different number. That is why we have 12 Hagars dilators, right? Then, the third complication of Hagars dilators could be if you are dilating forcibly. Now, when you forcibly dilate, that can lead to cervical incompetence. For all those students who feel that dilators are used to dilate the external os, remember, when you are dilating, your purpose is not just to dilate the external os. Your purpose is you have to go inside the uterus and you have to dilate the internal os, right? So basically, the dilators are used to dilate the internal os so that you can take the instrument inside the uterus, right? Now, one more purpose why I wanted to show you the dilator like this is, suppose if I ask you now a question, an MCQ, answer this MCQ for me. The instrument shown in the image is used for all except option A to measure the uterine length, option B to measure the cervical length, option C to know about the direction of the uterus, option D to dilate the internal os. So what are you dilating? You are dilating the internal os. Yes. Can you know about the length of the cervix? Yes, I can know about the length of the cervix. Can you know about the length of the uterus? No, because you are taking it only up till the internal os. You are not taking it up till the fundus of the uterus, right? So you do not measure the length of the uterus with this dilator. Length of the uterus you measure with the help of a uterine sound. Yes, it can give you an idea about the position of the uterus, whether the uterus is anteverted or it is retroverted. But it will not give you any idea about the length of the uterus, right? Now, one more use of the dilator. Can anyone think and tell one another use of dilator? One very important use of a dilator, which I forgot to mention in the previous slide, is if you have to diagnose cervical incompetence in a non-pregnant female. Now, if there is a female who comes to you and she tells you that she has history of 2 recurrent abortions, second trimester abortions in her previous pregnancies, and now she is a little afraid in conceiving. Now you are suspecting that yes, because she has 2 second trimester abortions, she could be a case of cervical incompetence. What is cervical incompetence? Cervical incompetence is when the internal os loses its tone. That is what is called as cervical incompetence. In a non-pregnant female, if I have to diagnose cervical incompetence, I can use a number 8 Hagars dilator. See, normally if the internal os will be of normal size, when you will put a number 8 Hagar dilator, the female is going to resist, right? Because the internal os would be closed. And if you try to put a number 8 Hagar dilator, she's going to resist. But if the internal os is open, in that case, when you will put number 8 Hagar's dilator, the female is not going to resist and you are going to come to know that yes, this female has cervical incompetence, right? So that was one more use of Hagar's dilator, right? Now, let's talk about, I have dilated the internal os. Now I want to do a curettage. Now, when I have to do a curettage, I am going to use a double-ended uterine curette, or since I have a double-ended uterine curette, or I can use a single-ended uterine curette. In a uterine curette, what you have to note is that yes, it also has loops at the end, right? So ring-like loops at the end, right? And it has serrations which are present on the handle, right? Now, depending on, you have to touch the instrument and see whether it is a blunt curette or whether it is a sharp curette. So, the curette which I have in my hand, one end is very sharp. So, one side is sharp and the other side is blunt. So, I have a blunt and a sharp uterine curette in my hand. It could be either ways. It could be a single, a single blunt curette or a single sharp curette, right? Now, this curette you shouldn't confuse with anterior vaginal wall retractor. I have both of them placed one above the other in front of you. If you look at the anterior vaginal wall retractor, if you look at the ends, they are much wider. The loops are much wider than what they are in a uterine curette. The second and the major point is that in anterior vaginal wall retractor, the ends in anterior vaginal wall retractor, although there are loops at the end, these loops have serrations. But in a curette, there are no serrations present. Third very important point. In anterior vaginal wall retractor, the serrations are present at the end. But in a curate, the serrations are present on the handle so that you can have a firm grip, right? So for a firmer grip, the serrations are present in the handle, whereas there are no serrations in the handle of an anterior vaginal wall retractor. And so this over here is anterior vaginal wall retractor. This is a double-ended uterine curate, which is used to do a dilatation and a curettage. Now, the blunt side is used to curate a pregnant uterus. So, in pregnancy, whenever this uterus is soft, I'm going to use a blunt curate. So, in case of missed abortion, in case of incomplete abortions, I am going to use a blunt curate. Or suppose after delivery, if female is having secondary PPH and you are suspecting that parts of placenta or fetal membrane have been, have retained inside. So in that case, I'm going to use a blunt curate and I'm going to check for the placenta or the retained parts of placenta or any membrane. Always in obstetrics, you use a blunt curate on a pregnant uterus except in one situation. And that one situation is after evacuation of molar pregnancy. After evacuation of molar pregnancy, you have to curate the uterus and you use a sharp curate, right? Otherwise, always for a pregnant uterus, we use a blunt curate. On the other hand, a sharp curate is used for gynecological procedures like for dilatation and curettage, or when you have to take out endometrial biopsy, or if the female is having excessive bleeding, that is atypical uterine bleeding, and you have to do an AUB, or suppose you have, in case of infertility, you want to do an endometrial biopsy, or in tuberculosis, you want to do an endometrial biopsy. So you can take out the curettings and you can send it for histopathological examination, right? So after talking about the instruments which were used in dilatation and curettage, now let's have a look at the instruments which are used for suction and evacuation, right? Now, as you all know that between 7 to 12 weeks, the best method for MTP is suction and evacuation, and this suction and evacuation is done with the help of a cannula, a plastic cannula, which is called as Carman's cannula, right? Now, this Carman's cannula, it has two tips. So, two openings here, not two tips, sorry. It has two openings here. One is here and the other is on the other side, right? And that is how you identify a Carman cannula, which is a plastic cannula. Earlier, we also had metal Carman cannulas, but plastic cannulas are less traumatic. That is why they are used, and then they are transparent as well, right? So, here you can see I have marked it for you on the image as well, that you are going to identify it on the basis of two triangular openings. Can you see two triangular openings? Yes. So on the basis of these two triangular openings, you are going to identify the Carman's cannula. Now, Carman's cannula, where it is used. See, Carman's cannula, it is used for doing suction evacuation for the first trimester, that is at less than 12 weeks. Then it is used for manual vacuum aspiration along with the manual vacuum aspiration syringe, which I am going to show you. It is also used for evacuation of molar pregnancy, and in gynae, it can be used for endometrial sampling. Although this is not the best instrument to do endometrial sampling, the best instrument will be an endometrial biopsy curate, right? The next thing is that what should be, the Viva question is, what should be the size of the cannula? Remember, the size of the cannula should be equal to the period of pregnancy, or it should be one less. And a very important Viva question is that the size of the cannula, it corresponds to what? So the size of the cannula, it corresponds to the diameter of the cannula in millimeters. So if there is a number 8 cannula, that means the diameter of the cannula is 8 millimeters, right? Now this Carman's cannula, it should be used with a manual vacuum aspiration syringe. Now it can be used rather. So this manual vacuum aspiration syringe is another very important instrument for identification. In the manual vacuum aspiration syringe, you have to remember that it has got two pinch valves. These pinch valves, they help to create vacuum, right? Then you have a collar stop over here. At the end, you have a collar stop. This collar stop, it helps to prevent the plunger from getting pulled back when the vacuum is created, and you have a plunger here, right? So it has two pinch valves, it has a collar stop, and it has a plunger. So you are going to, first you are going to close the pinch valves and you are going to pull the plunger back so that this, vacuum is created inside this MVA syringe. This is called as charging of the MVA syringe. Once you are done with this, then you are going to put this Carman's cannula at the tip. You are going to attach it and you are going to release the valves. When you release the valves, then the vacuum will be transferred and the product of conception is going to come out, right? So this is how you use a manual vacuum aspiration syringe. Questions which they ask you on a manual vacuum aspiration syringe is, what is the capacity of the MVA syringe? The capacity of the MVA syringe is 60 ml. Next question is, what is the pressure which is generated by the MVA syringe? Best answer for this question would be 660 millimeters of mercury, but if 660 millimeters of mercury is not given, then only you are going to mark it as 600 millimeters of mercury. Best answer is 660 millimeters of mercury. Then, it is an alternative to electronic suction evacuation. Normally, this Carman's cannula is attached to a suction machine. But in those places where there is no electricity, then you can attach it to an MVA syringe. So in rural settings, you can use a Carman cannula along with a MVA syringe to do MTP, right? And till what time can you do MTP by this method? You can do MTP till 12 weeks of pregnancy by using a manual vacuum aspiration syringe and a Carman's cannula, right? Then, another very important Viva question is, how do you know that evacuation is complete? See, there are three things which you have to tell to the examiner for the answer to this question. Number one, you are going to say that I'm going to know that the evacuation process of evacuation is complete when no product of conception comes out, right? Number two, when you will get a grating sensation. And number three, uterus is going to contract over the cannula. So these are the three things by which you come to know that the suction evacuation is complete. Now, if you have answered all questions very well, then the next question which the examiner will ask you is, do you know that there is a menstrual regulation syringe also? This is a manual vacuum aspiration syringe. How are you going to differentiate between a manual vacuum aspiration syringe and menstrual regulation syringe? That's very easy, and the moment you are going to look at it, you're going to realize how you're going to differentiate. In menstrual regulation syringe, you have a single valve, whereas in MVA syringe, you had two valves, right? So if there are two valves, it is an MVA syringe. If it is a single valve, then it is a menstrual regulation syringe. Next important question, that what is the capacity of this syringe? The capacity of this syringe is 50 ml. Of manual vacuum aspiration syringe, the capacity was 60 ml. The last question which they can ask you here is that till what time can you do menstrual regulation as a method for MTP? Menstrual regulation, it can be done up till 6 weeks of pregnancy or 6 weeks of amenorrhea, or in other words, till after 2 weeks of the missed period. So till after 2 weeks of the missed period, you can go for menstrual regulation as a method of MTP. Menstrual regulation is done using a menstrual regulation syringe in which there is a single valve, right? Now, so till 12 weeks, we were doing suction evacuation, and we were doing suction evacuation with the help of a Carman cannula. Now, after 12 weeks, if I have to remove the product of conception, if I have to do MTP, the method which I have is I can use a Haywood-Smith ovum forceps. For PG entrance students, for FMG students, a simple ovum forceps is what you have to remember. For final year students, you have to remember the complete name, Haywood-Smith ovum forceps, right? So, In a Haywood-Smith ovum forceps, again what you have to remember is after chittels forceps, this is the second forceps in which you are not going to get any lock. No ratchet lock present at the end. Very easy to identify this forceps because this forceps is a spoon-shaped forceps. The only forceps which you are going to get spoon-shaped is an ovum forceps. Spoon-shaped forceps, no lock, and on the spoon which is made, there are serrations present, right? So, why is there no lock in the ovum forceps? There is no lock in the ovum forceps so that just in case, a part of the uterus is held between it, then it doesn't get, it doesn't traumatize it, right? So, to make it less traumatic, it doesn't have any lock, right? Now, question which they ask you on ovum forceps can be, what are the uses of ovum forceps? The use of ovum forceps is if you have to remove the product of conception or if you have to do MTP after 12 weeks of pregnancy, then you use ovum forceps, because in that case the uterus is very soft. I cannot use a suction cannula, right? Then whenever you are using ovum forceps, you should always rotate it before you bring it out. So to be sure that you are not holding uterus in between. That is why you should always rotate it. Now, suppose there is a female who's having secondary PPH and you are suspecting parts of placenta or parts of membranes. Then again, with the help of ovum forceps, you can remove the parts of placenta, retained placenta or any membranes, right? So this is an ovum forceps. Now, before I start telling you the other instruments, very important question is the moment you are going to hold any of the instruments related to MTP, examiner is going to ask you about the MTP amendment which has happened in 2020. So all of you know that MTP Act, it came in 1971, but an amendment to the MTP Act came in January 2020. According to this amendment, now in India, MTP is legal up till 24 weeks of pregnancy. Earlier in India, MTP could be done only up till 20 weeks, but now it can be done up till 24 weeks of pregnancy. That's one thing which you have to remember about the amendment. Second thing which you have to remember about this amendment is that earlier you needed one doctor's opinion till 12 weeks of pregnancy, and then between 12 to 20 weeks, if you had to do MTP, you needed two doctors' opinion. Now they say that up till 20 weeks of pregnancy, that is up till 19 completed weeks of pregnancy, you need a single doctor's opinion. From 20 weeks to 24 weeks, if you are doing MTP, you need two doctors' opinion. Earlier, it was between 12 to 20, you needed two doctors' opinion. Now it is between 20 to 24, you need two doctors' opinion. That's the second thing which you have to remember about this amendment. Third idea is that now they say, suppose there is a fetus with gross congenital anomalies like anencephaly, and you know that anencephaly is incompatible with life. So in such cases, there is no upper limit for doing MTP. Anytime when anencephaly is detected, you can do MTP. But this gross congenital malformations, they have to be recognized by the medical board, right? So these are the three very important points you have to remember about the amendment which has happened in the MTP Act in January 2020, right? So, as I told you, Carmen's cannula, it can be used for taking out endometrial, for doing endometrial biopsy, but that's not the best instrument. This over here in my hand is Novak's endometrial biopsy curate. Now this Novak's endometrial biopsy curate, the identifying features are, if you see the distal end, it has a curve, right? It's angulated, a smooth angle which is going up. So the distal end or the distal tip is curved upwards. Then if you see the distal end, you will see an opening. In this opening, you will see multiple teeth, right? Can you see the multiple teeth over here? It is in these teeth that the endometrial tissue will come and stick, right, when you are doing the endometrial biopsy. Now, at the proximal end, you have a thumb rest and you have a stellate, right? This stellate is going to take out the endometrial tissue, number one, and this stellate is also going to help in cleaning the instrument, right? So this is an endometrial biopsy, Novak's endometrial biopsy curette. Now, endometrial biopsy is the procedure or the investigation of choice in case of endometrial hyperplasia. It is the investigation of choice in case of endometrial cancer, investigation of choice in postmenopausal bleeding, right? The next question which the examiner might ask you is that what are the indications for doing endometrial biopsy? The indications for doing endometrial biopsy are that if the age of the female is more than equal to 45 years and she is coming to you with atypical uterine bleeding. So this question was asked in AIMS June 2020 also. Question was that there is a female, 50 years old female with atypical uterine bleeding. What is the next step? So the next step has to be endometrial biopsy. So number one indication for endometrial biopsy is any female more than equal to 45 years who comes to you with atypical uterine bleeding. Number two, any female of any age, now the age could be less than 45 also, if she has history of unopposed estrogen. Now that history of unopposed estrogen can be in the form of HRT, it can be in the form of PCOS, right? Number three, if the female was having atypical uterine bleeding and her medical management has failed. Number four, if female has come to you with excessive bleeding and you got a TVS done, and on TVS, if endometrial thickness in a premenopausal female is more than equal to 12 millimeters, or in a postmenopausal female, if endometrial thickness is more than equal to 4 millimeters. In that case, you have to do endometrial biopsy. Other important points about endometrial biopsy are that endometrial biopsy is an OPD procedure and no anesthesia is needed for it. Right? So it's an OPD procedure, no anesthesia needed. A very important instrument, endometrial biopsy curette. Right? Now, this endometrial biopsy curette, which I have shown you, is a metal one. You can also have plastic endometrial biopsy curettes. Now, when they show you a plastic endometrial biopsy curette, it is highly, likely that you get confused between a Carman's cannula and an endometrial biopsy curette. Number one thing what you should remember is that usually endometrial biopsy curette will be very thin, right? In comparison to a Carman's cannula. But that is not the best way to differentiate it. Best way to differentiate between endometrial biopsy curette and a Carman's cannula is that in Carman's cannula, you were getting two triangular openings near the tips, right? I made you show these triangular openings. Can you see one triangular opening and the other triangular opening on the Carman's cannula? But on a plastic endometrial biopsy curette, you will get a single opening near the tip. You will have a single opening. Whereas in a plastic Carman's cannula, you will have two openings near the tip. So that's the best way to differentiate between a plastic endometrial biopsy curette and a Carman's cannula, right? Now, let's talk about a few forceps. Now, in the forceps, the first forceps which I want to talk about is this forceps. This is an Alice forceps. Now, as I told to you, in most of the forceps except the ovum forceps and the chittel forceps, you are going to get a ratchet lock. Right? So at the handle, we'll have a ratchet lock. So here also at the handle, we have a ratchet lock. Then what I want you to notice is the gap which is present between the blades. The moment you get a forceps with a gap between the blades, always think about Alice forceps. Now open the Alice forceps and then see the tip. Right? This is especially for the undergraduate students. Final year students, whenever you get an instrument, please do not be in a haste to answer that what the instrument is. Look at the instrument very, very carefully, examine the instrument and then give your answer, because the examiner is going to definitely ask you the identifying points, right? The identifying features. So if you look at the tip of the Alice forceps, the tip of the Alice forceps is curved inwards. Can you see? It's curved inwards, right? And the curved inward. And it has 4 to 5 rat teeth, 4 to 5 small teeth which are present on the tip. So again, I'm telling you the identifying features for an Alice forceps. A ratchet lock at the handle, gap between the blades are curved inwards, and when you open them, you get 4 to 5 rat teeth. Now, one more instrument which I pointed to you where a gap is present was the Cellum. So I am keeping these two instruments side by side, and now look at them. Now when you look at them, you'll understand that there is a lot of difference between these two instruments. A Cellum usually will be longer than the Alice forceps, right? Number 2, a Cellum will have a curved end. There will be a concavity, right? And as I told you, whenever you have to hold the lip of the cervix, you have to have the concavity facing upwards. Alice forceps, although the gap is there, there is no curve, right? There is no concavity. Clear? So this is how you come to know whether it is Alice forceps or a Cellum. Although both of them have multiple teeth. Both of them have multiple teeth, right? But in Alice forceps, it is a straight forceps. There is gap. There is no curve upwards. A Cellum is a much bigger instrument. There is a concavity upwards and the gap is there between the blades, right? Now, whenever there are teeth present, always these teeth, they help to hold tough tissues, right? So Alice forceps is used to hold tough tissue. What kind of tough tissue? Tough, non-bulky tissue, right? So if you want to hold a rectus sheath, right, while you are doing cesarean section or while you are doing abdominal hysterectomy, then you can use the Alice forceps. Or if you want to hold the vaginal vault while you are doing vaginal surgeries, like you are doing VVF repair or like you are doing Fothergill's surgery or you are doing anterior colporrhaphy, then you can use Alice forceps. Or a tough structure could be anal sphincter. So when you are repairing a 3rd degree or a 4th degree perineal tear and you want to hold the anal sphincter, then you can use the Alice. Apart from this, you can also use Alice to hold the fundus of the uterus, right, while you are doing hysterectomy, so that you can manipulate the fundus of the uterus. You can hold this, you can use the Alice forceps to hold a fibroid while you are doing myomectomy. Or you can hold the fundus of the uterus for one more thing. You can hold the fundus of the uterus during vaginal hysterectomy to bring the, uterus out. Right. Then another use of Alice could be if you want to hold the apex of the episiotomy while you are suturing the episiotomy. So all these are uses of the Alice forceps, right? Now this is the complete name of this is Alice tissue holding forceps. See, I told you that if the female is a pregnant female and if you want to hold the lips of the cervix, then you use a sponge holding forceps. If female is a non-pregnant female and she is multiparous, then you use a Cellum. If she is a nulliparous female and she is non-pregnant, then you use a Tenaculum. Suppose you have to do a surgery on the cervix of a child. Now, the cervix of the child will, it will be very small, right? So, a Cellum is not good for that purpose. So, in that case, you can use Alice forceps to hold the cervix of a child. If you are doing any surgery on the cervix of a female child, then you can use Alice forceps instead of using a Cellum. So, these are all the uses which you have to remember about the Alice forceps. Now, one more forceps which is used and is little similar to Alice forceps is the Cocker's forceps, right? Now, Cocker's forceps, it also has a ratchet, right? Cocker's forceps, how are you going to identify Cocker's forceps? When you open Cocker's forceps, you will see that this Cocker's forceps has one tooth on one blade and it has two teeth on the other blade. That's the identification mark. One tooth. Alice had multiple teeth, right? Alice had a gap between the blades. Cockers will have no gap between the blades, and when you are going to open it, you will see that there is a single tooth on one side and there are two teeth on the other side. The single tooth of one side, it goes into the groove between the two teeth on the other side and it gets closed. Apart from this, in the entire length of the blade, right, you will see transverse serrations. Entire length will have transverse serrations, right? This forceps is a Cocker's forceps. So, Cocker's forceps, the identifying features are when the instrument is closed, there is no gap between the blades. On one side, there are two teeth. On the other side, there is one tooth and the ends have multiple serrations, right? Now, Cocker's forceps, basically, it is used in obstetrics to rupture the membranes. That's number one use of Cocker's forceps. Number two, during abdominal hysterectomy, it can be used for clamping. You know, to clamp the pedicles, it can be used, right? Then, where other places are pedicles present? So, suppose it is a pedunculated fibroid. So, in that case, to hold the pedicle, I can use a Cocker's forceps. If it is an ovarian tumor or an ovarian cyst, so to clamp the pedicle of the ovarian tumor or ovarian cyst, I can use Cocker's forceps. And also, you know, I can use this to clamp the umbilical cord, right? So, I'm going to put on the umbilical cord, I'm going to put two Cocker's forceps like this, one here, and then I can cut the cord in between, right? So, these are the uses of Cocker's forceps. Apart from that, yes, Cocker's forceps can be used at all places where you were using Alice forceps. For example, to hold the rectus sheath, you can use it, but then they are not that, you know, for that purpose, it's not very good. If they ask you the uses, these are the uses which you are going to tell first, right? Understood the final year students? Okay. Then, now one forceps which I don't have, that's a green armitage forceps. If you have to hold the uterine incision, right? Then in order to hold the uterine incision during cesarean section, you use a green armitage hemostatic forceps. A green armitage hemostatic forceps is very easy to recognize because it will have a flat triangular end with serrations, right? So because it has a broad flat triangular end, that is why the hemostasis is much better. So although you could have used an Alice forceps also, so the place where you have given uterine incision and you want to stitch the uterine incision, you could have held the uterine incision with the help of Alice forceps also, but better is a green armitage, right? The advantage of green armitage is it has a very flat, broad end, but that is also the disadvantage. If green armitage is held for a very long time, then it can lead to pressure necrosis, right? So, I want you to look at this image here. This over here is a uterine incision which was given, and you can see that the ends of the uterine incision are held by green armitage. Just in case you don't have green armitage, so it is used to hold the angles of the uterine incision during cesarean section, and it is a hemostatic forceps, right? Just in case you don't have a green armitage, then you can also see here a cesarean is being done where to hold the uterine incisions we are using Alice. Now, without even seeing the blades, I am telling you this is Alice. Why? Because I can see the gap here. There is gap between the blades. The moment you see gap between the blades, you know that it has to be Alice forceps, right? So, this was a green armitage and Alice forceps and Cocker's forceps. All these were, the Cockers and the Alice, they were having teeth. Green Armitage was having a flat triangular end. Now we have a special kind of forceps apart from Cocker's forceps, where in Cocker's forceps I told you, you have one tooth here and two teeth here and transverse serrations. Similar to Cocker's forceps is Mangot's uterine clamp. Maingot's uterine clamp. In Maingot's uterine clamp also you have on the tip one tooth on one side and two teeth on the other side, but the difference is it has a longitudinal groove, whereas Cocker's forceps was having transverse serrations. So please look at this instrument very, very carefully. Mangot's uterine clamp. Mangot's uterine clamp and Cocker's forceps both have the same function and both have the same appearance. Only difference is in Cocker's forceps you will get transverse serrations. Can you see the transverse serrations? And in Mangot's you get a longitudinal groove, right? Use of Mangot's forceps is also for holding the pedicles during hysterectomy, right? So if you want to hold pedicles during abdominal hysterectomy, or you want to hold the pedicle of an ovarian cyst or an ovarian tumor, or you want to hold the pedicle of a fibroid, a pedunculated fibroid, then instead of using Cocker's forceps, you can also use a Mangot's forceps. Mangot's forceps, one side has a longitudinal groove, other side it has a longitudinal bar, right? This longitudinal bar will fit into the longitudinal groove on the other side. So one blade will have a longitudinal groove, the other blade will have a longitudinal bar, right? Now, when you are holding this forceps in your hand, the potential Viva question, and which could be an AIMS question also, the question could be that in which order are the ligaments clamped in case of abdominal hysterectomy and in case of vaginal hysterectomy. So remember, in abdominal hysterectomy, when you have to put the first clamp, you are going to put the clamp at the round ligament tubo-ovarian ligament, right? So the first clamp will be at the cornua of the uterus, and the cornua of the uterus has round ligament, it has fallopian tube and ovarian ligament. Then the second clamp will be put at the uterine artery so that the blood supply to the uterus is stopped. Third clamp will be at the cardinal ligament, and last the clamp is going to be put on the uterosacral ligaments. So this is the order in which you apply clamp in abdominal hysterectomy, right? The opposite will be in case of vaginal hysterectomy, right? Now, again, like Cocker's forceps was used to clamp the umbilical cord, similarly, you can use Mangot's uterine clamp also to clamp the uterine cord. Again, if you want to see the difference between Cocker's and Mangot's clamp, both of them will have one tooth and two teeth. But in Cocker's, there will be transverse serrations. In Mangot's, on one side, there will be a longitudinal bar, and on the other side, there will be a longitudinal groove, right? Now, the last forceps which I want to show you is a Babcock's forceps. Babcock's forceps, right? This forceps is very different from the earlier forceps which I have shown you. In all the earlier forceps, teeth were present at the distal end. Here, the distal end, there are no teeth present. It's flat. And the tip of the distal end, there is a gap, right? The tip of the distal end is curved and there is gap in between so that it can hold delicate tubular structures, right? This is a Babcock's forceps. Clear? Now, in Babcock's forceps, I'm repeating again, at the tip, there won't be any teeth. It will be flat. The tip will be curved and there will be gap between both the blades so that it can hold delicate tubular structures. Now, the delicate tubular structures which are held with the help of Babcock's forceps are fallopian tube when you are doing tubal ligation, right? Number one. Number two, round ligament when you are doing plication of the round ligament. Number three, ureters during Wertheim's hysterectomy or during radical hysterectomy. Number 4, you can hold spermatic cord as well. And number 5, appendix during appendicectomy. Right? So these are the tubular structures which can be held with Babcock's forceps. So suppose if they give you this image over here like this, they give you an image-based question and they ask you identify this forceps. So what will your answer be? Your answer will be this is a Babcock's forceps, right? Now let's talk about retractors. Now when I say that we use retractors, there are basically 2 uses of retractors. Number 1 use of retractor is to retract the skin and the tissues after you have given the incision, right? For example, I'll show you an image here. See here, right? So if you want to retract the skin and the tissues after you have given the incision, then you can use retractors. Number 2 use of retractors could be when you want to retract the abdominal organs, right? And you want a clear operating field. So there are 2 basically uses of retractors, and for these retractors, for both these uses, we have different kinds of retractors, right? First, I'm going to tell you what retractors are used for keeping the organs away from the operating field. Now, when we talk about keeping the organs away from the operating field, one organ which instantly comes to my mind is the bladder, right? Bladder has to be retracted during abdominal surgeries also when you are operating on the uterus, and it has to be retracted in vaginal surgeries also. Now, obviously, if you have to retract bladder in vaginal surgeries, you need a narrow retractor. So, for retracting the bladder in vaginal surgeries, we use a Landon's retractor, a Landon retractor. So, remember here, Landon retractor is L-shaped retractor, right? It's an L-shaped retractor. L for Landon, L for L-shaped. The blade of the Landon's retractor is at 90 degrees to the handle, and it has a straight and a narrow blade, right? So, a Landon's retractor is used to retract the bladder during vaginal surgery. So, suppose over here the bladder is there and I want to retract it. So, I'm going to use a Landon's retractor for the purpose, right? Also, if during vaginal hysterectomy, I want to retract the lateral vaginal walls, right? So, to retract the lateral vaginal walls also, I am going to use the Landon's retractor, right? L-shaped retractor, Landon's retractor used in vaginal surgeries to retract the vaginal walls and to retract the bladder, right? Now, same thing if I want to retract the bladder during abdominal surgeries, then the retractor which I use is a Doyen's retractor. It's very easy to identify Doyen's retractor from a Landon's retractor. Landon's retractor is L-shaped. It has a narrow flat blade, whereas a Doyen's retractor will have a curved and a broad blade. So it is used for retracting the bladder in abdominal surgeries, right? This is a Doyen's retractor. So you can see a Doyen's retractor being used here in this image, right? And this over here is Doyen's retractor. Doyen's retractor is a non-self-retraining retractor, right? Now, in abdominal surgeries, I just don't have to retract the bladder. I also have to retract the abdominal walls. In order to retract the abdominal walls, the retractor which I'm going to use will be a Morris retractor, and unfortunately, I don't have a Morris retractor to show you. So, you will have to see the image of a Morris retractor. So, what I'm telling you is to retract the abdominal wall in abdominal surgeries, you are going to use a Morris retractor. This is a Morris retractor. Now, what is important is that you have to know how to differentiate between Landon's, Doyen's and Morris. You can differentiate between Landon and Doyen's on the basis of the blade. In Landon, it is straight and it is at 90 degrees to the handle. It's narrow. In Doyen's, it is broad and curved. Now, in Morris, again the blade is at 90 degrees to the handle, and it is broad, right? And it is flat. So, if you are getting a blade which is at 90 degrees to the handle, but it is broad and flat, then that is not Doyen's, that is Morris retractor. Curved broad blade is Doyen's retractor, right? Now, a last retractor which you have to know is if you want to retract the abdominal organs. So when you are doing deep surgeries, for example, if you are doing ligation of the internal iliac artery and you want to keep the abdominal organs from coming in your field of work, in that case, I'm going to use a retractor which is a Deaver's retractor. A Deaver's retractor is very easy to identify. It is a question mark shaped retractor. Question mark shaped retractor. So whenever you get a question mark shaped retractor, it has to be a Deaver's retractor. Deaver's retractor is basically used to keep the abdominal organs, out of sight when you are doing deep surgeries, right? So now, quickly let us see. In abdominal surgeries, if you want to retract the bladder, what are you going to use? You are going to use Doyen's retractor. In abdominal surgeries, if you want to retract the abdominal walls, which retractor are you going to use? A Morris retractor. In abdominal surgeries, when you want to keep the abdominal organs away, then the retractor which you use is Deaver's retractor, right? Now, when you are using a Deaver's retractor, you always have to put a swab here and then you have to put the Deaver's retractor. Otherwise, that can lead to a little bit of trauma or injury as well, right? Now, all these retractors which I had shown you, they were non-self-retaining. In other words, the assistant will have to hold the retractor. But suppose you are doing very long surgeries. For example, you are doing Wertheim's hysterectomy and the number of assistants are also few. In that case, you can use a self-retaining retractor which is called as Balfour's self-retaining abdominal retractor. This is how they can ask you in the image. They can show you a retractor like this and they can ask you identify this instrument. This instrument is a self-retaining abdominal retractor which is a Balfour's self-retaining abdominal retractor. Now, how do you identify a Balfour's self-retaining abdominal retractor? I don't have a Balfour's self-retaining abdominal retractor. In the image, you will see that there is a transverse bar and to this transverse bar, blades are attached, right? One of the blade is always fixed. The other blade is a sliding blade. So on one end, you will have a fixed blade. On the other end, the blade will be sliding, right? And in the middle, the blade which will be there will resemble a Doyen's retractor, right? So this is a Balfour's self-retaining abdominal wall retractor. Clear? All these retractors which I told you, they were to retract the abdominal organs. Now, as I said that a retractor is also used to retract the tissues. While you are stitching the rectus sheath, you might want to put a retractor so that you can easily, stitch the rectus sheath. In that case, the retractor which you use is a Zerny's retractor. A Zerny's retractor is a Z-shaped instrument. It's Z-shaped. On one side, you will have two prongs and on the other side, you will have a solid blade. Right? So it's a Z-shaped instrument and this is Z for Zerny, Z for Z, right? So this is a Zerny's retractor which is used to retract the skin or the tissues, right? So these are the retractors which I wanted to tell you. Now the next instrument which we should talk about is the needle holder. Very easy to identify instrument because in this instrument you can see the blade is very small in comparison to the handle. I don't have a needle holder. You will have to see the image and you will have to, understand from this image. So the blade is very small in comparison to the handle. That's one thing. Number two is when you will open the blade, you will see that it has many crisscross serrations. Nowhere have I talked about crisscross serrations. In a needle holder, you get a crisscross serrations, and on both the sides, on both the blades, there will be crisscross serrations, and on one side, there will be an eye present or a groove present, right? An eye or a groove will be present. This eye or groove is present so that to prevent the straightening of the needle, right? So when you are holding the needle so that the needle doesn't straighten, that is why this groove or an eye is present on one side. Otherwise, both the sides, yes, crisscross serrations are present. Now, your Viva question could be that what is the ratio between the blade and the handle in a needle holder? The ratio between blade and handle is 1:4, right? The handle is very long. It is 4 times long than the blade. Number 2 question could be, how do you correctly hold the needle in a needle holder? Just show it to me, the examiner can say. So, in that case, remember, always you should hold the needle in such a manner that the needle holder should come at the junction of anterior 2/3 and posterior 1/3. So you have to place the needle holder at the junction of anterior 2/3 and posterior 1/3, right? So this is a needle holder. Now let's talk about scissors. In scissors, we have a Mayo scissor and a Metzenbaum scissor. A Mayo scissor is the normal, usual cutting scissor or the surgeon's scissor which you say. It is heavy and it is stout. So, a heavy, stout, short scissor is a Mayo scissor. Since a Mayo scissor is a heavy scissor, it is used to cut tough structures. Right? So tough structures like, if you have to cut an aponeurosis or a ligament or rectus sheath or any sheath if you have to cut, then you are going to use a Mayo scissors. Mayo scissors should never be used for dissection, right? It is a short, heavy, stout scissors, right? Now, Metzenbaum scissor is a scissor which is very light and it has a very long handle. That is how you're going to identify it. Always scissors and forceps can be identified on the basis that scissors will never have a lock, right? Forceps will have a lock, right? Now, how do you identify Metzenbaum scissor and a Mayo scissor? A Metzenbaum scissor will be a very light scissor and it will have a long handle. A long handle. That is how you identify a Metzenbaum scissor, and its tips will be pointed, right? A Mayo scissor can be a straight scissor also, it can be a curved scissor also. But a Metzenbaum scissor and a Mayo scissor, basically you can identify on the basis of, the length of the scissors and the heaviness of the scissors. Metzenbaum scissor is a very light and a long scissor, whereas Mayo scissor is a heavy and a stout scissor. Metzenbaum scissor is the scissor which is used for all fine dissections, and if you have to cut peritoneum, for delicate structures you are going to use Metzenbaum scissors like peritoneum, or if you have to do fine dissections, or if you have to cut, surgeons, if they have to cut the bladder or the bowel, then they use a Metzenbaum scissors, right? Now the examiner might ask you that between Mayo and Metzenbaum scissors, tell me, which scissor are you going to use for episiotomy? The cleverest answer would be that, sir, I'm not going to use any of these scissors for episiotomy. I am going to use the episiotomy scissors to give episiotomy. This is the episiotomy scissors. Now, as you can see in the episiotomy scissors, there is an angle present here. This is the only scissors which you will see angle present, right? Then you look at the blades. Both the blades, they have blunt ends, right? They are not pointed, but one of them is narrow and a little sharp blade than the other end, which is the other blade, which is broad and a little more blunt, right? So this is an episiotomy scissors. This is how you have to give an episiotomy. The long pointed end is going to rest on the vulva and you are going to give the episiotomy. Now, when they ask give you this episiotomy scissors in the hand, a number of questions can be asked. For example, the examiner can ask you that, where do you give episiotomy in all patients? You are going to say no, not in all females who are having vaginal delivery we give episiotomy. Episiotomy should be given only when it is needed. So what are the indications for giving episiotomy? Indications for giving episiotomy is when shoulder dystocia has occurred, or when there is a macrosomic baby, or when there is after coming head of breech, right? Or if there is a face to pubes delivery, or if it is a rigid perineum, like in case of primigravida females, and you anticipate that a perineal tear may happen, right? The next question which the examiner might ask you is, okay, tell me, what is the best method to prevent a perineal tear? Should you give episiotomy to prevent perineal tears? Is it recommended by WHO? You're going to say no sir, WHO does not recommend giving routine episiotomy as a method to prevent perineal tear. WHO says that when you are delivering the head of the fetus, with your other hand you should support the perineum. Right? So supporting the perineum with your other hand while delivering the head of the fetus, that is the method which is recommended by WHO to prevent perineal tear. Next question could be that what is the most common episiotomy which is given? The most common episiotomy which is given is a right mediolateral episiotomy, and in stressed condition, a right mediolateral episiotomy, it makes an angle of 60 degrees. So it is made at an angle of 60 degrees, right? Then in AIIMS also, this question was asked this year in AIIMS June 2020. What are the structures which are cut during episiotomy? Now, for answer to this question, I want all of you to watch the AIIMS Recall June 2020 session, which has been uploaded on Marrow channel, and the entire discussion I have done there. What are the structures which are cut during episiotomy? Then a very important question could be related to the next scissor which I am going to show you. The next scissor which I am going to show you is this scissor, a very peculiar scissor. You cannot make a mistake in identifying this scissor. Very small scissor with a coin-like end, right? Rounded coin-like end. This is a cord, umbilical cord cutting scissors, right? It's an umbilical cord cutting scissors. Now, normally umbilical cord is very slippery because of the Wharton's jelly, which is the special connective tissue of the cord. So, if you try to cut umbilical cord with the normal scissors, then it gets slipped. So, we have the special scissors for cutting the umbilical cord, and that is a cord cutting scissor, umbilical cord cutting scissor. The moment you get this instrument in your hand, you know the questions which can be asked. What is delayed cord clamping? What is early cord clamping? What are the indications for early cord clamping? And what are the steps which are included in active management of third stage of labor? And I'm sure all of you know these questions by now. So these are the questions which can be asked when you get an umbilical cord cutting scissors, right? Then, so I have cut the cord. Now, once the cord is cut, you have to clamp the cord, right, from the baby's side. Now, in order to clamp the cord from the baby's side, we use disposable umbilical cord clamps. So this over here is a disposable umbilical cord clamp. Now, a very important question is that where are you going to apply this clamp? This clamp should be applied 3 to 4 centimeters away from the umbilicus, right? Then, over here, I have a cone-shaped instrument made up of aluminium. This is a Pinard fetoscope or a Pinard fetal stethoscope. This instrument was earlier used to hear fetal heart sounds. Now it is not used, but then in your Vivas or as an image-based question, this can be shown. So this is a Pinard fetal stethoscope or a Pinard fetoscope, right? Now, the type of questions which you can get in Viva when you hold this instrument are, number one, they can ask you, where is the fetal heart sound located usually? So, suppose we have a baby here, the lie of the baby is longitudinal. Now, in longitudinal lie, which is the most common lie, the best place to hear fetal heart sound would be near the anterior shoulder, in the back near the anterior shoulder, right? So that is the place where you have to listen to the fetal heart sounds, except the exception is suppose the baby is in transverse lie. Now in transverse lie, the best place to hear the fetal heart sound would be near the chest, right? So that is the question which they can ask you. Next question which they can ask you is, what are all the Pinards what you have heard about? So number one is this Pinard fetoscope. Number two is the Pinard maneuver. Where was the Pinard maneuver used? Pinard maneuver was used to deliver the buttocks when in breech, in case of frank breech, right? So in Pinard maneuver, in case of frank breech, if you want to deliver the legs or the buttocks, what you did was you took your fingers up till the popliteal fossa, then you gave a little bit of pressure, the leg of the fetus came down, you held it and you brought it down like this. Same thing you repeat on the other side. So P for Pinard maneuver, P for popliteal fossa. So second Pinard is the Pinard maneuver. The third Pinard is the Pinard's living ligature. So if all of you remember, the middle layer of the myometrium is called as the living ligature because it has fibers running in a crisscross manner. So when the middle layer of the uterus contracts, the arteries which are there in between, they get constricted and the bleeding stops. So the complete name of the living ligature is the Pinard's living ligature. So you hear Pinard at 3 places, right? Now let's talk about some special gynae instruments. One of the special gynae instrument is this instrument, which is a Leach-Wilkinson cannula. A Leach-Wilkinson cannula is very easy to identify because the distal end of the Leach-Wilkinson cannula will be funnel shaped. Can you see this? It's a funnel shaped end, and in the funnel shaped end you have serrations, rounded serrations, right? They are encircling the funnel, and they are serrations present throughout the funnel shaped end, right? And the proximal end will have a stellate. So a funnel shaped cannula which you get is a Leach-Wilkinson cannula. Where do you use a Leach-Wilkinson cannula? You use a Leach-Wilkinson cannula to instill dye in HSG, in hysterosalpingography, and also in laparoscopic chromoperturbation. So a radio-opaque dye is instilled with this help of this cannula, right? Now, the question which they can ask you is, what is the best time to do HSG? So remember, HSG should always be done in the pre-ovulatory phase between 7th to 10th day of the cycle. The contraindications for doing HSG are a pregnant female. So whenever you are doing HSG, you should get a urine pregnancy test done. Another contraindication is pelvic inflammatory disease, and the third contraindication is genital tuberculosis. So whenever you are doing HSG, you should always get a test for TB done, right? And then you should go for HSG. Now, when you are doing HSG, it's a painful procedure. So half an hour before the procedure, you should give analgesics to the patient. So suppose if you do not give analgesics to the patient, what happens is, due to pain, the cornual end of the tube, it undergoes spasm. And because the cornual end of the tubes, they undergo spasm, so the dye is unable to pass ahead, right? In that case, because the cornual end will undergo spasm, so the dye will not be able to pass, and that is going to lead to bilateral cornual block on an HSG. So if your question comes, what is the most common cause of bilateral cornual block on HSG? If the examiner asks you this, you are going to say, ma'am or sir, this is physiological. That is because of the spasm of the tubes. Same question can be asked in your PG entrance exams also. But if the question is, what is the most common pathological cause of bilateral cornual block? Then your answer becomes genital TB. Clear? Then. Now, in case of HSG cannula, the Leach-Wilkinson cannula, you can see here that the tip was very broad, right? It's a funnel-shaped tip, but it's very broad. So, in multiparous females, yes, for doing HSG, you use a HSG cannula or a Leach-Wilkinson cannula. But in case of nulliparous females, the better cannula to use is a Rubens cannula. A Rubens cannula. So this is how a Rubens cannula looks like. It has a curved end, right? So the distal part will be curved and there will be a rubber stopper. So if you are getting a cannula where there is a rubber stopper and the distal end is curved, that is a Rubens cannula. So a Rubens cannula is used for doing HSG in a nulliparous female, and this HSG cannula or a Leach-Wilkinson cannula is used for doing HSG in a multiparous female. The advantage of Rubens cannula is that you can also use it to manipulate the uterus, so you can move the uterus with the Rubens cannula also, but you cannot do that with a Leach-Wilkinson cannula, right? Now, if I want to manipulate the uterus, I want to turn the fundus, or I want to turn the uterus during surgeries, I want to turn it, right? In that case, we use Hulka's manipulator. So this over here is the image of a Hulka's manipulator. Hulka's manipulator is something like a wall cellum, but it will have a long rod which will be attached to it. A rod-like structure will be attached to it, and then that becomes a Hulka's manipulator. Now, in the Hulka's manipulator, because it will have a wall cellum like this, so this end is going to get attached to the lips of the cervix, and the rod-like structure, it is going to go inside the uterus and you can manipulate the uterus, right? So you can see the image over here. This end is going to hold the lip of the cervix, and this is going to go inside the uterus and it will manipulate the uterus during surgeries, right? Now, there is a problem with this also, because this length is fixed. The length of the rod is fixed. So, suppose if the uterus is small, then it will not be able to move it because the rod will not reach up till the level of the fundus, right? Because this end is going to be fixed on the lip. And suppose this is the length of the rod which is attached to it, but uterus is bigger than this. In this case, this is not going to go up till the fundus of the uterus. On the other hand, suppose the uterus is small. In that case, this rod is going to perforate the uterus, right? That is why we do not use Hulka's manipulator these days. Clear? The next instrument which you should see is a Doyen's myoma screw. So it has a screw. Can you see here? A screw. This is a Doyen's myoma screw. This Doyen's myoma screw is used to hold the fibroid during myomectomy and to enucleate it, right? So this is a Doyen's myoma screw. Very, very important instrument, but very easy to remember as well, right? Now, another instrument which is used specifically in myomectomy is a Boney's myoma clamp. A Boney's myoma clamp is used to decrease blood loss during myomectomy, and this instrument is not at all difficult to recognize because this is the only instrument where you are going to see two pairs of finger grips. First pair and second pair, right? Now, in this instrument, there is a transverse bar over here and you have the handles. Between the handles, you are going to hold the isthmus of the uterus so that the uterine artery gets compressed and there is no bleeding. Not only are you going to hold the isthmus of the uterus, along the isthmus of the uterus, if you see in this image here, the round ligaments are also held, right? Now, the examiner can ask you, why do you hold the round ligaments along with the isthmus? See, when you will hold the round ligament will get taut, and that is going to help to keep the fundus, in upright position, right? That's number one. Number two, because round ligament will be present between the blade. So, over here, the round ligament will be present. Round ligament will be present between the blade and the isthmus. So, the compressing effect of the blade will not come on the isthmus or the uterus, right? So, that is why we hold the round ligament also along with the isthmus, right? Then, why are there two pairs of grips? Finger grips. See, the first pair of grip, if you notice here, the fingers are in the first pair of grip. The first pair of grip is to hold the isthmus of the uterus, right? And the second pair of grip is when you are doing myomectomy, because myomectomy is a long procedure, and for that very long time, if you keep this myoma clamp, that is going to lead to necrosis. So in between, after every 15 minutes, you have to release the clamp. So in order to release the clamp, you are going to use the distal pair or the second pair of finger grips. The first pair of finger grip is used to hold the isthmus. The second pair of finger grip is used to release pressure on the isthmus. So yes, this question can also be asked that at what time interval should the myoma clamp be released? So after every 15 minutes, you should release the myoma clamp. Now, another question which they may ask you is, what else can be used in a myomectomy to decrease blood loss other than a myoma clamp? So other than a myoma clamp, you can use a tourniquet. You can tie the tourniquet at the level of the isthmus and at the level of the cornua. Right? So when you are tying the tourniquet at the level of the isthmus, you are preventing the blood flow from uterine artery, and when you are tying it at the level of the cornua, you are also preventing blood flow from ovarian artery. Number one. Number two, you can inject vasopressin inside the fibroid. That is a vasoconstrictive agent, so that can decrease blood loss. Number three, you can give hypotensive anesthesia. And number four, before surgery, right, you can use GnRH analogs. So for 3 months, you can use GnRH analogs, and that will decrease the size of the fibroid and the vascularity of the fibroid. And all this will help in decreasing blood loss during myomectomy. Right? Now, what are the contributions of Victor Boni, right? So this was a Boni's clamp. So what other things are named after Boni? So there are 3 things which are named after Boni. One is the myoma clamp. The other is a Boni's test, which is done in case of stress urinary incontinence. And third is a Boni's hood surgery. Boni's hood surgery is a technique for removing the posterior wall fundal fibroid. So if there is a fundal fibroid on the posterior wall of the uterus, then you use a Boni's hood technique, right? So these are the 3 things which are named after Victor Boni, right? Now, this instrument which over here, you all know that this is an Ayer's spatula and an endocervical brush. Ayer's spatula, these days we use a plastic Ayer's spatula, but wooden Ayer's spatula is also available and is still being used in government setups. Now, in Ayer's spatula, the length of the spatula is 20 centimeters. It has a bifid end, and it is from this bifid end that you have to take a pap smear. Now, in this case, the longer limb of the bifid end, that is going to be on the external os, and this smaller bifid end, you are going to put it on the transformation zone, right? So the longer blade is going to be slightly longer side is going to be put on the external os, and the smaller side, slightly smaller side will be on the transformation zone, and then you are going to rotate it through 360 degrees. When you are going to rotate it through 360 degrees, entire 360 degrees for 2 to 3 times, then the entire transformation zone would be covered, right? Then the other things which you have to remember, endocervical brush, you know that it is used to take the pap smear from the endocervical area. Now, before doing a pap smear, there are certain things which you should remember. You shouldn't do any pervaginal examination. Then you should advise the patient not to use any lubricant before a pap smear. Number 3, when you have put the smear on a slide, you are not going to air dry the slide, right? Then the question can be on what time should pap smear be started and at what frequency should you do a pap smear. So that is the screening method. So all that, again, if you want to know anything and everything about pap smear, I have covered it in the AIMS recall session of June 2020. That is a video which is uploaded on Marrow. You can go and watch there. A very important question about pap smear is the preservative which is used in pap smear. The preservative which is used in pap smear is 95% ethyl alcohol. Earlier 5% ether was also used, but now it is not used because ether is highly inflammable. So now labs, they are not using ether. Now it is just 95% ethyl alcohol, right? So these are the instruments which I want you to have a look. The last instrument which I want you to look is a tubal ring applicator. Now, this is an instrument which is used to apply Fallop ring, right? So when you are doing tubal ligation with a Fallop ring, then you use a tubal ring applicator. This end, these are the prongs, right? And this over here is the proximal end where your fingers are going to go, and this is a Fallop ring. A Fallop ring is made up of silicon, but it has got barium sulfate, which makes it radio opaque. And where are you going to put the Fallop ring? You are going to put the Fallop ring at the isthmus of the tube, right? So you are going, with the help of this ring applicator, you are going to put the Fallop ring in the isthmus of the tube. Approximately how far are you going to put it from the uterus, from the cornua of the uterus? Approximately this Fallop ring will be put 3 centimeters away from the cornua of the uterus, right? So that completes my discussion on instruments. I hope all of you have enjoyed this session as much as I have enjoyed telling you. If yes, please do press the like button and don't forget to leave a comment for me, because your comments and your compliments, whether they are positive or negative, help us to do better. If you want more such videos, final year students and the PG entrance students, do write to me in the comment box what topics you want. And yes, I will try to bring more videos for the final year students also related to case discussion. So one video on case discussion definitely I'm going to come up with, and we are going to see how it goes, and then we can decide whether to continue with case discussions on YouTube or not. Repeatedly, the pre-final year students have been requesting me to give them a strategy of how to prepare for their next exam. So yes, I am going to bring out a video very soon for them on the strategy also. In the meanwhile, keep studying, keep safe, and keep your spirits high. Take care. Bye all of you.